Welcome to the Public Health Nursing Clinical Skills for Infant Assessment. In this video, we will demonstrate the assessment of a normal 2-month-old infant. Growth measurements will not be demonstrated. Before the exam begins, review the chart for perinatal history, growth data, feeding method, the completed developmental screen, and the caregiver's completed Edinburgh screen. Identify any areas that need to be focused on during the clinic visit. Collect any equipment needed to complete the assessment. These may include an eye paddle occluder, pen light, fixation stick, or a sticker placed at the end of a tongue depressor. Brightly colored objects such as those located in the comfort kits. Lastly, the recommended calibrated equipment for measuring the baby. Always wash and warm your hands before touching the newborn, and remember to try to avoid letting the baby get cold. The assessment starts with the baby fully dressed and ends with the infant fully undressed and ready for weight measurement. For the demonstration, you will see the exam performed in sequence. However, in reality, the exam begins the moment we see the infant. The assessment sequence may change due to the flow of the visit and the baby's comfort. The care provider's handling of the baby is an opportunity to begin the assessment without disturbing the baby. We can note how the caregiver handles the baby, their interaction, and bonding. Is the baby dressed appropriately for the weather? Is the baby crying or settled? If crying, we note the quality of the infant's cry. In an older child, we would listen to the child's voice, noting speech and the nature of the sounds. We glance at the facial features for any obvious dysmorphisms. Is the baby working hard to breathe or making any grunting noises? We note the baby's skin color. Is it a typical pink, or is there evidence of cyanosis, pallor, redness, or jaundice? We can then assess the gross neurological state of the baby by looking at the baby's posture, noting head control and neck motion. We check the positioning of the limbs, noting symmetry, flexion, hypertonicity, hypotonicity, and spontaneous movement of the hands and the eyes. We look for abnormal movements such as tremors, twitching, or jitteriness. We begin our exam by looking at the baby's face. Does the infant's face have any milia or newborn acne? Observe the eye's gross anatomy, including the eyelids, orbits, conjunctiva, sclera, cornea, iris, and pupils. Note presence of a palpable slant or epicanthal fold. Palpable slant and epicanthal fold are typical in people of Asian descent but abnormal in others. Using a light, the examiner should inspect for excessive tearing, watery or purulent discharge, photosensitivity, conjunctival infection, and gross structural abnormalities. The infant's sclera and conjunctiva should be clear with no evidence of redness or discharge. Pupillary response should be assessed for shape, size, and symmetry. At that time, the gaze, the ability to focus, and the gross eye movement should have been noted. By 2 months of age, infants begin to more easily focus their eyes on the faces of a parent or other person near them and begin to display facial expression as they fixate. Any rapid, involuntary shaking type movements or nystagmus would be abnormal. We will now look at the baby's nose a little more closely. Look for the position and symmetry of the nares, noting an absence of nasal flaring. There is a general rule for positioning the eyes and nose bridge. Each should occupy an equal third for placement. An increase, hypertelorism, or decrease, hypotelorism, is often associated with abnormalities. Look at the baby's mouth for size, symmetry, and movement. When the baby's mouth is open, inspect the tongue for size, position, and the presence of plaques that could be consistent with thrush. Examine the gingiva for neonatal teeth and the buccal mucosa for white plaques. The hard and soft palates can be assessed by inserting a gloved finger along the whole length of the palate to ensure there are no clefts or deformities. Moving to the ear assessment, were any pre-existing high-risk factors for deafness identified? We look for confirmation that a universal newborn hearing screening was completed in the birth history. Inquire if the caregiver has noted any concerns regarding the baby's response to sound. All ASQ3 developmental questionnaires ask about parental concerns regarding their child's hearing. Observe the ear pinna for symmetry, shape, appendages, and movement. The position of the ear is noted in relation to the corner of the eye. Low-set ears may suggest underlying congenital problems such as renal anomalies, fetal alcohol spectrum disorder, or Down syndrome. Next, examine the ear structure for the patency of the external auditory meatus to ensure that it has well-formed cartilage. Next, we examine the head and the neck, noting any previous history of molding, cephalohematoma, caput succedaneum, forceps, or vacuum marks. We observe head control during movement. The infant should have displayed a full range of head and neck motion. Is there a good range of movement, or is the child favoring one position? Look down at the head from above to check shape and symmetry or evidence of plagiocephaly, flathead. Palpate fontanelles while the child sits upright and record the head size on the WHO growth record. Lastly, we assess the scalp for hygiene and skin integrity. Clean, pink, and smooth with no evidence of lesions or cradle cap. Next, we expand our view of the baby's skin, checking for rashes, erythema toxicum, bruising, irritations, or lesions such as petechiae, eczema, impetigo. We complete a general inspection of limbs for any obvious deformities, asymmetry, bowing, lumps, or bumps. We examine the spine's alignment by turning the baby gently to the side. Look at the color of the skin and note if it is warm to the touch. We test the child's skin turgor by gently pinching a fold of skin on the abdomen. When the skin is released, it should return quickly to its original state. If it does not, the child may be dehydrated. As our eyes move over the baby, we note areas of abnormal pigmentation or nevi, hemangiomas, and Mongolian spots. Start with an inspection of the shape of the baby's chest for symmetry and any signs of respiratory distress. These would include accessory muscles such as subcostal or intercostal indrawing. Observe respiratory efforts such as nasal flaring, grunting, or noticeable adventitious breath sounds such as crepitations, bronchi, or wheezing. Note the contour of the abdomen. Are there any apparent masses, bulges, or peristaltic waves, or does the abdomen seem grossly distended? The umbilical cord should be well healed by this age with no evidence of redness, discharge, or other signs of infection. Primitive reflexes may be included as part of the infant assessment depending upon the infant's age and other findings during the assessment. The Babinski reflex is a primitive plantar reflex for the toes to try and attempt to grasp your thumb or your finger when the sole of the foot is firmly stroked. Next, the palm of the baby's hands is gently stroked, eliciting the grasp reflex. This reflex is typically present until an infant is 9 to 12 months old. Perform the grasp reflex in one hand and then the other hand, and then bilaterally to note the presence and symmetry of this reflex. The root reflex is performed by stroking the baby's cheek. Depending on the state of arousal and when the baby was last fed, the baby may not elicit this reflex. The tonic neck or fencing reflex can be produced when the baby is lying down and the head is turned to the right or left. The corresponding arm extends while the other arm bends next to the head. This makes them look like they're about to start fencing. This reflex lasts until the baby is about 5 to 7 months old. The stepping or walking reflex is typically present until 2 months of age. The baby takes steps or dances when held upright with their feet touching a solid surface. The Moro reflex is last, as it is quite startling to the baby and includes quick abduction of the arms, followed by adduction and flexion of the arms and a startled look. To produce this reflex, the baby's head must be gently held in our hand with our arm braced on the bed. Then it is a very short but rapid descent of the head that elicits the classic Moro reflex. Then proceed to do a gender-specific genital inspection. Always wash your hands before touching the newborn and after examining the genitalia and diaper area. Remember to avoid letting the baby get cold. In boys, the genitalia is examined for formation, structure, and placement. The glands and foreskin are inspected for color, edema, or any discharge present. The normal foreskin is loose and has a pinkish pigmentation. If circumcision was completed, there should be no loose foreskin. The urinary meatus position is located centrally midline on the tip on the glands. In hypospadias, the opening is found on the undersurface of the penis. To conclude the genitalia exam, we visually inspect and palpate the scrotum to locate the testes to ensure that both are descended into the scrotum in infants. Testes should be symmetrical in size and shape, with the left testes often lower than the right one. The hip assessment is the final part of the exam. Begin with a general inspection of the hips, including the skin folds of the thighs for symmetry. Look for any asymmetry in the creases and the length of the limb segments, which may include a dislocated hip. Then do a passive range of motion at the hips. This includes flexion, extension, abduction, and adduction. After performing the passive range of motion, move on to the special maneuvers performed to identify whether the hip is dislocated or prone to dislocate. This involves two special maneuvers, the Barlow and Ortolani maneuvers. These are only completed on infants under 2 to 3 months of age. After this age, these become less effective in identifying hip stability because the soft tissue development prevents the hip from being relocated. It is also not recommended that these maneuvers be performed in a fussy, crying infant whose muscle activity may inhibit the movement of an unstable hip. Barlow maneuver begins with the infant flexing the knee and the hip to 90 degrees and brings the thigh towards the midline, adducting the hip. Mild pressure is placed on the knee while directing the force posteriorly. A dislocation will be palpable if the femoral head is pushed out of the socket. The Barlow test is considered positive if the hip can be popped out of the socket with this maneuver. The Ortolani maneuver places the examiner's first finger over the greater trochanter, takes the infant's hips through flexion 90 degrees, and then quite a significant abduction. The point of the Ortolani maneuver is actually to reduce a dislocated hip. The feeling the examiner gets is a perceptible clunk or click as the head of the femur relocates into the acetabulum. Again, any clicks or clunks should be referred for further assessment. At this point, we should have a good understanding of the infant's overall health status state. It is essential to document your findings regarding the baby. This examination shows a healthy, well-developed 2-month-old infant free of any abnormal findings.